Hello everybody and welcome to Hughes Clues for Bariatric Surgery. Our patient is a 45-year-old female. She's 61 inches tall and she weighs 220 pounds, which gives her a calculated BMI of 41.6. She's been overweight since childhood, poor results with previous diets, obesity-related comorbidities such as hypertension and hyperglycemia, but she believes that if she can lose the weight, then she can decrease these comorbidities and control them without medication. What makes her a candidate for bariatric surgery? I know that the exam blueprint will list bariatric surgery as either 2 to 3 questions, but I think it's important to know that 2 to 3 questions, one of those questions could be a select all that apply. I've created a little laundry list here of all the things that make her a candidate for bariatric surgery. I'm not going to read through them. A lot of them are common sense things, but just kind of get a sense of all of the things that go with this that make her a candidate so that you'll be prepared. There are 3 different types of bariatric surgeries. How do they differ and what advantages and disadvantages do each offer? The first one we're going to talk about is the Roux-en-Y gastric bypass. This is the most common, and it is considered a combination of restrictive and malabsorption surgery because what happens is the surgeon will create a pouch of the upper portion of the stomach to where now this pouch will only hold 20 to 30 mils, and it's essentially completely closed off from the lower part of the stomach as well as the duodenum. Then the second part that makes it restrictive, that's what makes it restrictive, is creating this 20 to 30 mil pouch. And then what makes it malabsorption is we slice and dice through the jejunum here, so that's the second portion of the small intestine, and we take that one end of the jejunum, and this would be further on down would be the ileum, and that is connected to that small pouch. In other words, you have stopped all flow from the bottom end of the stomach through the duodenum and the upper jejunum. Now you have this small pouch here, and then that drains directly into the jejunum down the ileum and the rest of the gut. So the stomach is in effect bypassed. And again, it's combination surgery because you have the restrictive piece and then you have the malabsorption piece because you've changed the physical anatomy of the of the gut. Malabsorption, of course, is because it's all about how the food substances are essentially absorbed. You've rewired the upper digestive tract. The advantage of Roux-en-Y is that it's most commonly performed because the better weight results occur. And this will also help these individuals take care of the comorbidities that have really caught or caused them to seek health. There's something about the duodenum. I think there's even some studies out that when the duodenum is bypassed, blood sugar control is better even in individuals who have, for instance, type 1 diabetes and who are not necessarily overweight. There is a lower incidence with this Roux-en-Y of malnutrition and diarrhea. Here's the disadvantages. There can be a leak in the anastomosis, and if you're not familiar with the term, what you've got here is you're making this unusual or abnormal connection, and where this jejunum is sutured into that little pouch of the stomach is called the anastomosis, and this can leak. If these sutures kind of are not tight enough, it can leak, and therefore you're going to have gastric contents, intestinal contents, especially acidic contents that are going to leak into the peritoneum. That's a bad thing. Also, anemia can occur because that's from the malabsorption. You're not able to absorb iron and folic acid as well, so you'll have deficiencies. You'll also can get a calcium deficiency, and dumping syndrome can occur. Dumping syndrome just means that the small pouch can dump very quickly into the jejunum, and when it does that, the individual will get nausea, vomiting, and diarrhea and dizziness. And a lot of times dumping syndrome is caused when the individual doesn't eat the way they're supposed to, so they can avoid the dumping if they'll eat how they're supposed to. The second type of procedure that we're going to talk about is gastric banding, and you can see there's a picture here. All they're doing is putting a band around the upper portion of the stomach, and what that does is it does create a small patch so that the individual will feel full more quickly, but it still allows for the passage of food to go the regular way. You haven't completely cut off the upper portion from the lower portion of the stomach. You've just made it smaller. And there's staples that are used above the band to create a smaller gastric pouch, I guess, to really restrict that. So that's why it's called a restrictive surgery. The advantages is there's no anastomosis, there's a lower risk of infection, and then the anatomy and physiology is more normal, because even though there's a pouch, it still allows food to go slower down the normal drain pipe, but that also helps give you a feeling of fullness. The disadvantages is there's higher complications rate. The weight loss is a lot slower. There's a rupture of the staple line, a dilated pouch, and you get a dilated pouch and then all you've done is no benefit, because that means that they'll be able to fill that dilated pouch with a whole lot more food and they're not going to lose the weight that they expect to lose. And any of these gastric surgeries can have dumping syndrome if they don't eat the right way. The third surgery is lap banding, and this is where a band encircles the stomach. Again, it's just creating a smaller pouch, and it's restrictive because the stomach is now 30 mils inside. If you'll notice this little gizmo, this is the advantages, is that the band can be adjusted up or down. If they're not losing enough weight or they're losing too much, then this little port, I guess, is accessible, and they can change the amount of, I don't know if it's air or saline or whatever, it's like a breast augmentation, if they can just increase or decrease that. It's reversible, no dumping syndrome, and of course lack of malabsorption because you have the food passages on the normal pathway. The disadvantages is low complication rate. That should probably be up in the advantages. Some nausea and vomiting. Initially, band may slip or erode into the stomach wall, and again you have a gastric perforation, which is going to cause acids to leak and enzymes to leak into the peritoneal, and then problems may occur with the adjustment of the band. The patient is scheduled for a Roux-en-Y gastric bypass 1 month from today. She admits to smoking 2 packs of cigarettes. So what if you're the pre-op teaching person? What kind of pre-op teaching is needed prior to the surgery? Well, it's really important for her to understand about skin prep. You guys know that when you have obese patients, there's a lot of skin folds, and unless that individual is very diligent in lifting those folds and cleaning, there can be all kinds of little microbes that can rest and reside in those folds. So these individuals, before the surgery, they need to really vigorously lift and scrub those folds. There needs to be DVT and PE prevention, and of course anybody that is smoking is at increased risk for DVT and PE. You want to educate the importance of incentive spirometry. You guys know that anytime you have abdominal surgery, patients do not want to cough, turn, and deep breathe, and of course that puts them at risk for atelectasis and pneumonia. This patient had the surgery, the Roux-en-Y gastric bypass, and they're admitted to the ICU post-operatively. Here's a listing of your vital signs, and then you have your ABGs. Take a moment to pause the recording and look at all of these all of this data, and then identify the nursing care challenges that you can point out from looking at these vital signs. When we look at the nursing care challenges, you can note that there is an elevated systolic blood pressure. And again, when you have a patient that's large, that's a little obese or is obese, you need to be sure that the blood pressure cuff is the correct size, because a small blood pressure cuff can sometimes overestimate the systolic pressure. Notice the respiratory rate, it was 10, and the typical respiratory rate of an obese patient is hypoventilation. And that is because they cannot really drop their diaphragm very far, because their stomach, the adipose of their stomach is in the way, and so this decreases the ability of the lungs to expand. And what about the ABGs? What did you notice? Well, if you said or determined that you have respiratory acidosis without complication, then you're correct. The pH is decreased or acidic, and the PCO2 is increased because the patient is not breathing very rapidly. It's a respiratory rate of 10. This is respiratory hypoventilation, and all other values are okay. Again, you're going to have to nag and ensure that this patient will turn, cough, and deep breathe. With a short, fat neck, the patient has an increased risk for aspiration. The head of the bed should be elevated at least 45 degrees, should lie on her side, and flat supine decreases the expansion of her lungs and increases the risk for aspiration. So increasing the head of the bed is a twofold benefit. Obese patients often have veins that are difficult to find. Be sure you protect the IV side as you turn this individual. What about the pharmacologic agents used to prescribe pain? Well, patients undergoing bariatric surgery, they're going to be in pain and abdominal pain. And if you don't control that abdominal pain, the patient is not going to want to move and or breathe deeply. Pain medication should be given as frequently as possible. Of course, you always have to weigh the benefits and the risks because fentanyl is the analgesic of choice. That's an opioid. And when you have an opioid on board, then you can have respiratory compromise. And that's in addition to the fact that you've got a short, fat neck and you've got hypoventilation. So it's a threefold kind of risk. Identify additional complications that can occur in this population. Again, you've got this band or you've made the stomach smaller, so therefore you can have regurgitation, and then you can also, because it's a stressor, you can have ulcers occur. So of course we want to give us some kind of proton pump inhibitor or a histamine blocker. We want to do an insulin drip because again, obese patients may or may not be hyperglycemic, but the presence of hyperglycemia will increase the risk for infections. Obese patients, for whatever reason, have a higher fibrinogen plasminogen activator. That's all a bunch of fancy stuff with their clotting. The bottom line is hypercoagulability. That means they're at a greater risk to produce COTS, and that's not taking into account that now this individual who is immediately post-op is not really moving around much. So pretty much all patients that are not moving around are at risk for DVT and PE. Add in the obese patient and you have a double risk. So this individual will need some kind of prophylactic sub-Q heparin or Lovenox. Within several hours of her arrival, the patient begins to complain of abdominal pain. She appears flushed. Her vital signs are 110/60, 77, 118 is your heart rate, that's beats per minute, 32 respiratory rate, and 101.4 is your temperature. What could be happening? Well, the most common early post-op complication is a wound infection. And the infection could be related to just poor blood supply to the adipose tissue, excessive moisture, accumulation of bacteria in the folds, or just from the wound issue. Wound dehiscence means that the pieces or the skin has kind of slipped apart from each other, and this puts an individual at risk for an increased infection risk. Her elevated heart rate and temperature may be a sign of infection. In other words, you really need to think, is this SIRS? And you might not say to yourself, well, we haven't covered SIRS, we haven't covered sepsis, and that's true. But I just want you to think that infection, and then if you have signs and symptoms of a rapid heart rate, rapid respiratory rate, then that's SIRS, and that could be sepsis. Sepsis carries a high mortality, and so this patient is at a big risk. Let's talk about a rare but serious early post-op complication is the anastomotic leak, and that's what we talked about earlier, where the suture line kind of either is not tight enough or it actually slips, or for whatever reason now you have gastric secretions and gastric enzymes that are leaking into the peritoneum. And this is probably because it's a serious and early complications, something you want to remember. When we look at an anastomotic leak, the signs and symptoms are sustained tachycardia and fever. Well, that's kind of pretty generic because that could be sepsis or an anastomotic leak, but really if you had an anastomotic leak, hey, you're at risk for sepsis, so it's the same thing. Leukocytosis, decreased urine output, and that's because whenever you have sepsis or you have an inflammatory response that's really heightened, then you have vasodilation and your urine output will go down. Severe abdominal pain and distension. This is going to be the key signs and symptoms, these last three, that are going to really determine whether you have just a run-of-the-mill infection / possible sepsis or that you have an anastomotic leak. So that's a severe abdominal pain and distension. That's going to tell you if you have peritonitis because your abdomen is going to be rigid. Location of the pain may be referred to the back, left shoulder, and the patient may experience hiccups. Note, 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 these last three, that scream at you that you have your patient has an anastomotic leak. A wound infection is diagnosed. IV antibiotics and hydration are always going to be initiated. Feeding is begun and well tolerated. The patient is recovering. Let's talk about the teaching points of home care, because you know as soon as they return from the operating room, well, you got to start discharge teaching. Patients who have just had bariatric surgery, they can be unsuccessful in maintaining the prescribed diet. Individuals that are obese have had a history and a presence of some poor eating habits or increased volume in their eating habits, and so it's very hard to change that. Just because you've changed the anatomy doesn't mean that the brain and the mindset is changed. So here's your changes while ensuring an adequate intake for body's nutritional needs. And this has to do with the fact that all of those surgeries really do make the stomach smaller. You've got a 20 to 30 mil size stomach now. So you've got to decrease the amount of food that you eat, but you got to do really good type food. In other words, it's got to be high protein, low carbohydrate, low fat, and low roughage. We don't want roughage because that kind of hangs in the stomach for a lot longer, and we don't need that. We really need very high protein diet. And they got to do 5 to 6 small feeding a day, and this will help meet their nutritional requirements. Their fluid intake is 1,000 mils per day. Again, if you have an individual who is a big-time water drinker, well, let's go ahead and just drink a large glass of water before we're supposed to eat, and you can imagine with that 20 to 30 mil pouch, the fluids are going to take up the space, and then they're not going to meet their nutritional needs because they're not going to be able to hold anything. And then, of course, they want to sit up after eating because you've got this really small pouch, and you can have regurgitation, and you don't want reflux. Let's talk about late complications. 4 to 6 weeks post-op, you can have an incisional hernia, your nutritional deficiencies that we makes sense. Let's talk about cholelithiasis. Here's the deal. You know that your bile is meant to digest fats, and you've got an individual who is no longer eating a high-fat diet, or really they're supposed to, if you look back here, they have to have low fat. So therefore that bile is just kind of sitting around in the common bile duct and sitting around in the gallbladder because it's not needed, because you're not eating a lot of fat. And of course, anything that hangs out and just stays or has stasis will cause stones to form. And so these individuals often will have to have gallbladder surgery after they have their bypass surgery because of this cholelithiasis bile issue. The anastomotic strictures, in other words, you get the scar tissue that's formed because anytime you have some kind of surgery, there's the process of inflammation, and that scar tissue can form in that area and create strictures. And so especially if you have the banding or the gastric the lap band or the gastric band, you've made that area very, very small for food products to drain on down through the bottom part of the stomach. And if you have a stricture because of scar tissue that's formed, then that can be an even worse problem because now you're not going to drain out. And of course, all is well with this patient. She returns to the clinic for her follow-up visit. She's already lost weight and she is feeling great. That's pretty much sums up bariatric surgery very quickly. If you have any questions, be sure and email me.